Storage and elimination of urine and feces involves a coordinated set of back-and-forth signals along neural pathways between the pelvic region and the brain. During bladder filling, sensory or afferent signals convey information of bladder fullness to the brain via the sacral nerves. When functioning appropriately, the response to a bladder-full sensation at a socially appropriate time is efferent signals from the brain back to the bladder, causing a motor response. The pelvic floor relaxes and the bladder detrusor contracts, which results in urination. The proposed mechanism of action is similar with defecation. As the colorectal space fills with fecal material, nerve signaling results in contraction of the external anal sphincter to prevent defecation. Once the sensory signals reach a level where the need to defecate is perceived, a voluntary decision to proceed sends signals that cause the external anal sphincter and puborectalis muscle to relax. While the abdominal and diaphragmatic muscles contract to expel the stool. Dysfunctional operation of these neural pathways can result in overactive bladder, non-obstructive urinary retention, and fecal incontinence. The general consensus is that sacral neuromodulation delivered with the interstim systems provides stimulation of sensory or afferent nerves that modulate both the sensory input to the brain, affecting subsequent efferent signals along the spinal circuits that are involved in storage and voiding or defecation control. The effects of sacral neuromodulation are believed to occur primarily by normalizing the dysfunctional sensory signals that travel to the midbrain via spinal tract neurons. This may help alleviate involuntary urination, non-obstructive urinary retention, or involuntary defecation without affecting voluntary response, which is the clinical outcome usually observed with sacral neuromodulation therapy for the treatment of OAB and FI. This allows patients a return to more normal active lifestyles, free from unexpected symptoms or events.